And Sunday, next Sunday.
Picture this.
Officially 1920.
And then I'll go and ask the next thing, and send it out.
Oh.
What time is it at?
What? Wait, so what time do you go to?
.00, but we're one panel member short of a quorum, so we might wait just another minute or so, and then we'll get started. We've got a couple of our guests on, and told them they didn't need to be on until closer to 1:30, but we're getting close. Well, there we hit quorum. Give Jason a minute to get settled, and then we'll start. Okay, well, thank you everyone for joining us today for the advisory panel meeting. Our agenda primarily today is to start exploring one of the questions we've been asked to make a recommendation about in terms of privatizing the operations or the pros and cons of that. So we have some national folks to help provide some background and thoughts about that, but we'll get into that here in a little bit. We've got some status updates we want to provide to the panel as well. So I'll call the meeting to order. We've got a quorum with a few people on the call by Zoom. So you've had a chance to look at the minutes from the February 23rd meeting. I'd entertain any additions or corrections. Representative Helgerson.
No additions or corrections. Move the adoption of the minutes.
Got a motion to adopt.
I can second.
Jason Gregory seconded. Any discussion or changes to the minutes as distributed? Seeing none. All those in favor of approving the minutes, say aye. Those opposed, say nay. Hearing none, the minutes are approved. Just so we can I don't want to miss anybody who has something to add, and that's a little more complicated on Zoom. So if you can use your raising your hand option, I'll be able to see that and make sure I can call on you. Particularly for the panel members, I want to make sure you have opportunities to weigh in as you would like to. Next, Lisa Pelkey with the Learning Tree Institute is going to give us an update on the results from our town hall meeting on February 26th. We had the Greenbush team do a survey at the town hall, and then for a few days afterwards, and just wanted to make sure the panel was aware of the results from that. So, Lisa.
Thank you. So this is going to be about a 5-minute overview, try 4 or 5 minute overview. If you have questions after, I may not have it memorized, but I can sure get you the answers. So know that I don't have all of the data memorized. Again, my name is Dr. Lisa Pelkey, and I'm a statistical analyst with Greenbush, and I am helping collect data for this project. On February 26th, which was a Monday, from 6:30 to 8:30, Sedgwick County and KDADS hosted a town hall at Wichita South High School. It was also live streamed for individuals who were unable to attend. It was also recorded, and it is available on the KDADS YouTube channel. Participants had the opportunity to view 2 presentations, one by KDADS and one by Sedgwick County. These presentations provided the most recent updates on the project. Approximately 143 people attended in person, and 10 attended on the live stream. Participants were given note cards to submit questions, and 38 questions were submitted. No questions were omitted. So every single question that we received, we read out loud. We did receive 4 note cards that did not have a question that also contained personally identifying information. For example, one card said, I have schizophrenia. When I was hospitalized, I wasn't told by a doctor or counselor that I had schizophrenia. Please educate people on how schizophrenia can impact your life and relationships. Most importantly, how important it is to stay on medications. It's like any other health condition, such as heart issues or diabetes. So 4 statements that were similar to that. In addition to the town hall, participants were provided with a QR code to submit comments. 18 zip codes were represented. Most of the zip codes were from 67217, which is the location of the proposed facility, and that was with 5 people. Out of the 153 participants, 37 submitted comments. The top 5 themes of the comments were location concerns. Should we build it here? Is this a suitable site? The second one is community engagement, the desire for transparency and involving the community. The third theme was need and support for mental health services, a feeling of gratitude that the facility was going to be built, and that additional resources were going to be coming into the community. The fourth one was staff and workforce concerns. They were concerned about how you will hire and retain staff. And the fifth one was alternative site suggestions. People provided names of possible alternate locations. Additionally, after the town hall, for 6 days, residents were provided a QR code to provide comment outside of the town hall situation, and 42 residents took advantage of that opportunity. And their comments largely echo the in-person comments. There were 8 residents from the 67217 zip code. Most participants from the town hall and the survey were from the surrounding zip codes right around the 67217 zip code. In the report, there is a map that has all the participants together on the very last page in Appendix C, so you can see like the density of participants. Specific details can be found in the report. Other than that, I think though those are the main, those are the highlights.
Any
Any-
questions for?
Yeah.
Dr. Pelkey? We've got the full technical
Yep.
report that we can send out again, or it's posted in a couple of different places, but if you need that additional documentation.
The questions that people asked are also in the report. They're edited for grammar and spelling, but they're in there. So you can see what types of questions people were asking.
And there was some kind of interpretation of the question to make sure it was a question that either Tanya or myself or Commissioner Lopez could answer, but the full text of the questions are in the report.
Yeah, there were really only four note cards that did not have a question that were similar to the person with identified themselves with schizophrenia.
See any other questions? Thank you, Lisa.
Yep.
Take a little bit of time for project updates. Ask Tanya Cole to come up from the county and provide an update.
Okay, good afternoon. Tanya Cole, Assistant County Manager. Nicole is passing out a couple of documents that I'm going to go over. Wanted to give you an update on the land and design, which is what we're working on right now. As far as the land goes, we are working with Lang, and where we're at with that is we are working on the zone change, and we've got 3 dates to take it through the process of the zone change. So April 11th, we will go before the Metropolitan Area Planning Commission. And we are not, of course, the applicant, but we will attend to be able to answer any questions that the Planning Commission may have as part of this zone change. And then April 1st or May 6th, we'll go before the District Advisory Board, and that's District Advisory Board 4. And then May 14th, we'll go before the City Council for this zone change. And so we feel that as far as the purchase agreement goes, once that's all been signed off for the zone change, we should be able to solidify the purchase agreement most likely the end of May or early June. And so as I mentioned at the town hall, we were looking at 90 to 120 days. And so that fits right in there with that 120 days. So I'll stop there and ask if there's any questions on the land piece. Okay. Okay. So
you might just share
sure.
what the zoning change is, or
okay.
what's being asked of the zoning board
Sure.
to look at for the site.
So right now, that particular parcel that we're looking at is general commercial, and we're looking to change that to limited industrial. And the reason for the zone change is because of course, for the forensic beds that we'll have, and that has that correctional piece to it. And so that's why that is requiring that zone change. Okay, so let me move into the design. One piece that I wanted to share with you is this large 11 by 17. What I just wanted to show you there is kind of the piece at the top there. Basically, what we're doing here is a partial 2-story build. And if you can see, and I'm sorry for those that are on the Zoom, I don't know if you won't be able to see this because it's so finely detailed. But so this is your schematic design. And if you can see, there's kind of a diagonal line kind of at the very top piece here that shows the full schematic design. There is a small portion, and this is the front entry right here. There is a small portion here at the front that we're going to build 2 stories to this particular facility. And the 2 stories are going to be simply for efficiency, and the 2-story portion of this facility will only be for administrative. So it's going to be offices. Everything else that for this facility that's going to be 1 story is going to be, the rest of it will be patient spaces. So everything else around there that you see And I'll try to describe the colors, and Scott, you may have to help me a little bit. But your green is basically your administrative area. So as far as security, it's a very it's a lower security area where patients won't be going into. Your red and your orange, those are your patient areas. So that's a higher security area. And then your yellow, that's also a patient area, but that will be where staff will be located. And then your blue is where, patients are going to be walking through, but they will be with staff. So just wanted to show you that the facility will have that small portion of a 2-story build there. So as far as progress, where we're at with design, I will tell you that we are about 1 week behind schematic. We had kind of a conversation today with Pulse Design. They're not too concerned about it. They think that we can kind of crunch the time to gain that. But we are trying to move into design development, which gets us into a little bit finer detail past schematic design. We did see the site plan today, so that's basically taking the schematic design and putting it on the site, and it looks really, really good. I can tell you that. I'm hoping to share that just as soon as we can get that from Pulse. They showed that today to us for the first time. And so once we can get that and they've defined that a little bit better, if there's not a meeting coming up, I'd like to send it out to the panel so they can see that, because I was really pleased with how that layout looks on the site. Okay, and then the third piece I want to share with you is this this document. And so this is the costs. And this is what Senator Reddy asked for at our last meeting. And so I want to go into this in a little bit of detail. And I want to start at option 3 and the left side. And so what we're looking at here is if we were to build the hospital as we've talked. And so this would be the 52 bed facility as is. So no expansion, no anything. And so what I'd like you to focus on is, and we talked about this, $650 a square foot. So if you look in the middle column, the price per construction, and I'm really having a squint here, but I think it's a little over 60 million. And then what you see down here, all of these additional costs, when you get to the bottom line, that's in bold, about 79 million. That's your total project cost. So that's everything inclusive of this project. So 60 million for construction, 79 million total for a 50-bed mental health hospital. If we were to go in later and build the additional 50 beds later, that additional cost would be 43 million to build 50 beds. Let's say we just threw in 5 years later. And then the additional cost in total for those for that project would be about 55 million to do that 5 years later. So in sum, you're looking at a total of 147 million to do that at a later time. Is everybody tracking with what I'm saying there? Okay. So I've got 2 other options here to throw out there. If we were to build 50 beds and then build 50 beds shelled out. So what that means is you're basically just building your walls for 50 beds later, or 50 beds now, but to fill it in later. So all we're doing is building the structure of the additional 50 beds. That construction cost, and again, refer to that middle column, construction is 69 million. Total is a little over 90 million. And then if you fit those 50 beds later, 27 million for construction. So I've gone over to the right side, and then a total of, I think 34 million. So in total there, you're looking at 137 million total to do that. So we would build the 50 beds in total. We'd shell out the other 50 beds. That's 90 million. And then if we fit them out later, so we did everything else, we came in and we did the medical equipment, we did the furniture, fixtures, equipment, IT. That is an additional 34 million 5 years later. So 137 million total. If we could get the funding to do the entire 104 beds now, refer to your middle column, that's 97 million. If we could do it all now. So I think that was the cost that Senator Reddy was asking for, and I'm happy to answer any questions. And again, this is at I want to refer to that middle column. This is at $650 a square foot. Yes, sir.
Could you go through that? You said 97 million is what it would be to build the full 100+ beds now.
Correct.
And if we put it off for 5 years, and I don't know your inflationary factor, it was 130 some million.
That's correct.
What's the inflation factor?
Do you remember what, I don't, let me check with him on that. I know he was saying 5 years. Andrew, do you remember what he gave us? No. I don't know, Representative, let me go back to Pulse and see what their inflation factor was on that.
So we save roughly 30 some million by spending it, doing it all now and filling it in.
Correct. Doing it.
If we can't staff it now, but to spend it all now rather than later.
You're correct.
Would also seem like it would be worthwhile, even if the state had a bond to save that money and have it all built in that period.
And that's what we're trying to illustrate here is that it's much cheaper to do it all at once now, even if you're going in 5 years later and, you can do the shell out. I mean, even that's cheaper than doing 5 years later, building the walls. I mean, if we could even do the walls now, that's even cheaper to do that.
We had talked at one time that maybe do a second tier on top.
Mhm.
Is this second tier on top of the beds or is this spread out?
No, this is this model right here.
This is this model.
This is this. This is 104 beds right here. So this would be building this entire facility.
With the only small portion out of the second story.
Correct. That's correct.
Okay. Somebody gonna put this in writing? And I don't mean this, but I mean simple 1-page or a 2-page document that says, Representative Helgerson, this is, if you spend 90 some million dollars for this, we do 100 and some beds. If we try to do, 5 years later, we have all the inconvenience and the hassles and everything else. And our projected cost is 136.
I'm happy to do that for you, Representative.
Yeah, we need that.
Tom?
Yeah, I'm clear on option 2 and 3. On option 1, just to repeat, the build now number estimate average is 97,600,000. The 114,750 on the far right-hand side, that's if we delay the project. By
No, thank you for asking that. So if you see so I've always referred you to the middle column. If you can see on the left and on the right, it says 10% low, 10% high. So basically what we've done there is kind of given a range. And so that's based on kind of where we're at when we go to bid, based on kind of market, where we're at with labor, where we're at with construction. We've kind of put in, because we don't know what we're going to get for a bid. So that just gives us a range. Yeah. And so that 114 is basically given the price. If you look to the right of that, that's that 10% high number.
And 10% more than the $650 a square foot.
Yeah. That's all I have
Other
this.
questions
Yep.
for Tanya? Sorry, Representative.
No problem. We had another task that not the full committee, but individuals had with regards to the estimate of the other facility. Is that going to come up?
We hadn't planned, we hadn't planned to share it today for the other, the option of of Riverside Hospital being considered, that we talked about last month. We did have Pulse take our schematic design, so programmatically what we need to have in this project, and map that to the Riverside Hospital building, including some things that aren't in the existing footprint that we'd have to build, and some things that we'd have to demolish, and then applied a price to that. And it didn't, the couple of elements of that. One, there'd been a suggestion that in the Riverside Hospital building, we could build 165 beds. Pulse's opinion was that that wasn't possible, given the administrative space that we have to have and the number of floors in the building and how you could convert them for usable space. They ended up having the same number of beds, so their estimate was for 104 beds inside that structure, compared to what we have here. And it did come up, it was a little bit more expensive. We can share that information with the panel if that's of interest, but I think it ended up being more expensive than our build, and with the caveat of it's an existing structure. We've got asbestos removal. We've got some other hazardous or methane on the site, things we'd have to take care of, and what the potential cost for those things might be. So we've done that exercise. We've shared it with the legislators that asked about it. The governor's office can certainly share with the panel as well. But what we've done what we were asked to do for that exercise too. Yeah, Representative.
I haven't had a conversation with the other legislators, but I want to be prepared, and my fear is somebody's going to put a proposal in front of the appropriations committee or in front of the budget committees that are negotiating the budget, and say, we still want to go this direction, and this is the comparison. We think it's your figures, and not that they're wrong, but are different. And it's helpful to have this committee look at it and make a recommendation. If it is to stay with the same site, then to say the same site, but it's also helpful to have a recommendation from this committee saying, not only do we think that the original site is the best site, the phase for building all of it at the same time makes better financial sense for us. It's much better to have this group making that recommendation, and I can carry it to the legislature and the governor has, rather than me repeating some of these words. Does that make sense?
Sure.
And I don't know if you were thinking of having any of that discussion. Monday, we're going to start negotiating the budget. So those are my concerns.
Sure.
I could have a senator pop up and say, we're doing this, and we think we should actually go to the Riverside Hospital. And anything that I have to say, this is what the committee says, helps me a great deal.
We documented from our last meeting in the minutes. I don't know that everybody weighed in, but a number of panel members did, on thoughts about the two sites and where we are in the project. I can certainly distribute that cost estimate that we did to the panel, and you can look at it and provide more feedback from there, the understanding the timing for next week when conference committees are meeting. But I feel like we're prepared to respond to that. You have to make a good point that if the panel wanted to recommend something, I'm not haven't and try not to have you all vote on something and where we have to do things by consensus when we can. If we couldn't reach that point, I don't want to put anybody in an uncomfortable situation. I feel like I know what my marching orders are. So I feel comfortable with where we are, but I'm happy to certainly ought to share the estimate with the panel so you all have the information as well. And then you can decide if there's another recommendation that the panel would like to make and discuss.
Well, not backing anybody into a corner, it's 135 versus 90 some million right now in the figures.
Can I give you that exact number? Because I've got it in my portfolio.
And if I have some kind of indication from the committee that says, we think it's better to spend 135 now, or it's 97 now, rather than 135, that's helpful to say, because we're all gonna share it in taxes. It's just whether or not we're gonna pay more later or less now.
Let me make sure I understand your question. Are you asking about going from 50 to 104 beds or the
Goes
different-
50 to 104, and if we made that decision, then it's better to have the 104 beds. How do we finance it? And you know, those are helpful because
Sure.
Yeah, just so everybody understands, people don't want to spend an extra $50 million or $30 million down for stuff, Sedgwick County. And we have enough things in the works here, so it's helpful to say this makes good financial sense. If it makes for good financial sense, I don't want to twist anybody's arm, but if that's the case, it really helps both the governor and me in trying to leverage this in the next few weeks.
The panel's recommendation in the interim report was to two things. One, suggest that building a larger facility was more preferable to the 50 beds. But subject to looking what the cost comparison was. Well, how much more does it cost to build 104? So you've got that information today. So I guess that would be the next step of if we wanted to revise that recommendation or make something more formal, that given with the panel, and I mean, those of you in the room have it, I need to send it to the rest of the folks who are either on the Zoom or not at the meeting today, so they can look at the same information and then decide if they want to make a recommendation about, given the information of the cost, we're really sure we want to build 104 beds or something different, but sure.
So, and I know you're going to answer that question in a second, Tanya. And so I would agree with Representative Helgerson that two things that I think this committee should really consider is a recommendation on this sheet here that Tanya went through, and that building it out totally right now, the cost of it is much cheaper than the other two options. And it doesn't mean it all has to be staffed immediately, because we already know staffing is going to be an issue, but at least the building's there and it's paid for. And so I think that's something that we as a group should look at as a recommendation to push forward to the governor as well. The second piece of that is if there is some comparison out there, because you hear a certain person throwing out numbers. This here, what the county has done actual comparisons and actual costs of what this will be, and gives us a good understanding of how much this project was going to cost. If there is information out there that another study has been done in a similar fashion, then on the Riverside Hospital, I think all of us should be privy to that, so that we can provide a recommendation on that as well, which also includes the cost of the property, not just what the build is, including the cost of that property. And that would be my recommendation as well.
I just wanted, just to speak for myself, there's been two sides of this since this committee started meeting. There was the operational qualitative side, and then there's dollars and numbers. I think this committee has talked about the qualitative side of building something that is safe for staff and safe for patients and state of the art. And it's very difficult in any building, in an existing building, to make a hospital out of it. This is. So from a qualitative perspective, I think this, at least I have been leaning toward, let's build something that's going to last for 50 years and serves our clients well and is safe for our staff. And then I've not seen any numbers, and I know Tanya's going to share numbers, but I've not seen any financial numbers which would indicate that what we're leaning toward on this new build site is fiscally more responsible. I'm not seeing that yet. And so I'm going to, with Representative Helgerson, let's go for the cost-effective model. And comes down to Tanya options here are pay me now, pay me later scenarios. And I don't know what the inflationary rate is, but I'm going to tell you, in the world of building and construction, it's not normal inflation. We're seeing inflation rates that are above and beyond CPI rates nationally. So this, I'll be interested what Pulse used as an inflationary rate, but I'm not sure that they're estimating enough in the world of construction, because I know what's going on in this region and in this state in the world of building, and supply chain and labor on that front is going to be significant. So I just speaking for myself, and if there's a motion made, I would be glad to listen, but I think we have to tackle this from two angles.
One other point that I would like to make is that with the reason that we're doing this is to help out the state mental health hospital as a state. And so the reason we were talking about bringing it down here was because of the amount of population that comes from this county. And so when you increase those beds to 104, which I'm supportive of, we haven't talked about catchment areas yet, but it does help the rest of the state, because it creates that environment for folks to be coming here to the Wichita area that creates bed space opening in Larned and Osawatomie, which is something that we've talked about for 7 years to help out the state system. And this applies to that. So I just want to make that point to also Mr. Helgerson, since you're going to be the one speaking to it. I think that's a big point on this, because 104 beds will increase the catchment area, which then helps out the rest of the state.
Can I jump in?
Yep,
So
please.
Andrew came over and answered the question of inflation. When you go to the right side, which talks about the 5 years later, your square footage rate jumps from 650 to 850 a square foot. So that's the inflationary rate on that.
And that center estimate.
Correct.
column, okay.
Yeah. Okay, and then just to answer Representative Helgerson, he is correct. When we looked at the Riverside Hospital to do the 104 beds there, with everything included as far as doing upgrades to the facility and the basic infrastructure to the facility, and then fitting 104 beds for mental health, we were looking at 135 million for that particular facility versus our 97 million for new build at MacArthur Meridian.
And that included the purchase price of the property, or that's
Correct.
just the construction cost?
Included purchase price. That's what you provided, I think,
Yep.
to them.
So I need to share that analysis with the panel. We need to get this to the remainder of the panel, and then see how we can either try to advance another recommendation. I can be happy to draft some language and see if that's something that the panel wants to endorse once you've, I don't think it's fair to ask anybody else to vote on it when particularly Claudio and Mary and Commissioner Lopez aren't seeing the same information that everybody in the room is, let alone the people who aren't here. So we can do that first part and then draft a recommendation that might go from what we did in the interim report, which was to say the panel, I don't remember the exact, I could look it up, but endorse the idea of a larger facility of 104 beds, but wanted to see what the costs were. Now that we've got the cost estimate, would make a recommendation to the governor and legislature to fund that in this budget, the next budget. I'll work on language, and then we can see if that's something that the panel would want to endorse. We're not meeting in April because the subpanels are going to meet, but we can certainly do that we can distribute electronically and vote on it and get that feedback, hopefully in time. That'd be valuable to the discussion next week.
Scott?
Their question, you could say so, but when you shared that information of the comparison office and the legislators that have reaction, and it may be unfair, and you may not have things like.
Reaction. Well, I won't speak for the legislators. I'll talk about giving it to the governor's office. They said that to them, it looks like that means following the path we're on of our own building project. The project direction that we've been working on with the county, that this panel's aware of, is the better choice because it's cheaper and it meets all of the goals and objectives of the project. And the other building would not meet all the objectives of the project, and it's more expensive.
still where I'm getting confused and this might be taking us in a direction we don't want to go is there's already been a letter of intent with the city on the riverside. And there were already negotiations for the land here. I don't, what the train's already out of the station. I mean, I don't understand how, I mean, it seems like there'd be litigation for things to change. Not that I support change it.
It's a fair point. The legislators appropriate money and decide where it goes. So, I mean, that there's that decision point along the way as well. Mark, your hand's up, so I want to make sure I don't miss out on you. And Claudio's got a comment in the chat.
Well,
Go ahead.
yeah, I guess I want to put a finer point on this. Representative Helgerson's saying that Monday they begin the negotiations and the discussions about where money is going to be spent. And to the point that was just made, what's going on in Wichita is fine, and what the county commission and the city council may have done and made decisions is all good and fine. But the legislature is not beholden to those decisions. Is going to go up and in their money, where they're going to spend the money, and those decisions are going to be made beginning Monday. I think what Henry's asking for is something more definitive, not waiting a month, not waiting for all of us to see this, but something more definitive. And I guess I want to pull us back to that. I don't want to move on yet. And what I'm suggesting is we're not in a position to make any binding decisions, but we could make a recommendation at the very least. And I'd like to hear if Henry thinks this is good enough, but at the very least, I'd consider making a motion that suggests that we all vote up or down on whether or not we recommend to the governor and to the legislators who make these decisions that they give strong consideration to the document that Tanya has laid out for us verbally. I haven't seen it personally, but I accept what she has said that shows that there is a cost benefit to Sedgwick County, but also to the state writ large to build this facility out now. And that if they're going to consider another facility, that at the very least we have one study that we know about, the one that Tanya just laid out. So I'll put this in a more concise motion that can be voted on. But I guess I'm not chairing this, but if I was, I'd say, what argument? Let's hear people's thoughts on that. But my concern is if we wait, since we're not meeting next month, and we wait until the end, decisions may get made in the vacuum of a lack of clarity from us. So if they do it, at least I'll know where we stand.
I completely agree with that.
Henry, is that to your point? Am I getting closer to what you were asking for?
You are, but I hate to, push you too far. Push the group because you're just getting the figures now. But it seems pretty obvious to me, and literally we will make billion-dollar decisions in the next week. And I need to start leveraging. But let's also, even if we don't take a formal motion, I look around the room and there's some heavyweights in this room that can lobby some of the other legislators, or they can say that we totally agree in this position of moving ahead on the 100 and some bed facility at $90 some million. And, I'm available to answer to the committee or to the legislature if they have questions. I prefer your motion, but at the same time, I don't want to put anybody that it's a premature until everybody has a chance to look at the figures.
Go ahead. I'm sorry.
One last thing, because Henry Helgerson saying something is one thing, and they'll listen, but at the same time, they'll also listen a little bit more if I can tell them that the board independently took a resolution and said, you're stupid not to make the decision that I'm talking about.
Barry, your hand was up next.
Yeah, thank you for that. I was just going to say I have a lot of agreement here. I think it is important that if we feel like we have enough information at this point, we should put the recommendation in place. I think what we've seen so far is a lot of things that have tried to deter the work that we're doing. And if we feel strongly about the increase in beds and the evidence is also there for the site that we feel like is the strongest, I would be comfortable and think it's in everyone's interest to put that down in some type of formal way.
Mark, if you had the language of a motion, I was following you and then you added a second item to it. So the first part that I thought was a clear recommendation was that the panel would recommend to the governor and legislature to build the 104 beds proposed in the project, given the information that the panels received about the cost, the costs now versus building doing it in phases or over a longer stretch of time.
Real quick, Tanya, if I refer to your study for others, how do I refer to it? What is it called? What would you call that?
What?
Mark, help me understand. Are you talking about the comparison study or the
comparison?
Okay. I
Just
think
laid out between the two. Yeah.
I think we just called it the mental health hospital Riverside reuse and new analysis study.
New analysis study. Okay.
Correct.
Okay. So I think then, because it's going to be recorded.
Maybe before you make a motion, Claudia, your hand was up. I want to make sure I get any comment before we state a motion that we'd vote on. Claudia, go ahead.
Yeah, Scott, the only thing I would add to that is, has there been any operational pro forma completed that would, document the economic value and benefit to the state as a whole and to taxpayers that would maybe help accelerate a recommendation or a decision? Because on the cost or on the merits of the capitalization, it makes sense to do that now. Is there additional information that, again, can accelerate an operationalizing of this that would show that economic value to the taxpayer? I'm just curious if that has been done.
We've been working on the staffing difference to go from 52 to 104. It's not quite double, but it's almost twice as many people that we need to employ. So we haven't translated. I mean, that's been enough of a lift. We haven't translated that into the tax impact of going from 150 employees to 250 employees in the Sedgwick County area, but there'd be some proportional change in that. But we've done some of the operational costs, but not that economic impact that you're asking about.
Yeah, in the comparative study, was there any analysis on staffing pressure between the two, a new build site versus and to Claudio's question of long-term pro forma, was there any analysis done in comparison to those two options?
There was, and I'm going to actually defer to Scott on that because Scott provided the information as far as staffing between the two comparisons.
We did just looking at the building designs and trying to figure out the staffing model for what you've seen in the new build, and then looking at the Riverside Hospital building, we said, well, the hallways are longer. There's more patient rooms on each floor. The sight lines are longer, so it's going to take more people. We're going to have slightly more nursing, significantly more direct care staff to be able to supervise patients across the building. I don't know that we quantified it exactly.
You did?
Did
Yeah.
I? Okay.
Can I refer to it? Okay.
Yeah,
So in here, it says KDADS estimates 7 to 10% more staff on each patient unit based on the unit configuration compared to building from scratch.
We didn't put a price on that, but we did come up with that much of a difference based on just the floor layouts. So I think we're back to, I'm leaning on Mark if he's got a motion to wording for a motion.
All right, so I'll do this on a dry run first, make sure that the language is appropriate. So listen, and then if it's, unless there's some wordsmithing to do, then this will be the motion. In light of the Sedgwick County Mental Health New Analysis Comparative Study, the vote would be, we recommend to the governor and legislature that they approve the full build out of the 100+ beds. And I don't remember the exact numbers, 104,
104.
104, the 104 bed facility at the, I'll call it the MacArthur location. Period. I'll just leave it at that. I think that is concise enough that we know what we're voting on. But if someone wants to change that, let me know.
That's the motion. Is there a second?
I would second that.
We've got a motion and a second. Any discussion about the motion or clarification about the motion? Latasha, you joined a little bit later. If you've, and you're not shy, so if you had a question you'd ask, I just wanted to make sure.
Yeah, and Scott, I just put in the chat box that I can abstain from the vote because I didn't hear the full breadth of the discussion, although I think I'm caught up per the end with some of the questions that were just asked. So either way, but thank you for clarifying.
Yep, no problem. Any other discussion about the motion? Not hearing or seeing any. How about, so all those in favor of the motion, say aye.
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 Any objections, say no. Hearing none, the motion's passed. So thank you for that. We'll get that from the transcription. So we've got it available for Representative Helgerson and others, particularly myself, because I'll be monitoring those discussions next week as well. I'm still going to share with you or make sure everybody's got the cost estimates that Tanya shared today, the comparison study, all those things. So you have that information and I guess if that's your weekend reading and you want to change your mind, we can change direction, but I want to make sure you've got all the information as well. But Representative.
One further clarification, and I know an individual on this panel has raised this concern and a desire to privatize the staffing. The motion does not preclude us moving in that direction or the state moving in that direction. And I just wanted to add that so that if that comes up in the discussion, that they understand that our motion is related to whether or not there's an attempt to privatize the staffing of the facility.
And my motion, for clarity's sake, had nothing to do with that. I'm simply saying that for the benefit of some over $30 million in cost savings, as reflected in that study, I believe we're all on the same page that I would hope people would take that into strong consideration as they're considering how to spend that money.
So I have a follow-up question and Mark, when you were talking about what we just voted on, you also had put in there originally talking about these comparative studies also being allowed to be sent, or Mr. Helgerson to be able to share those with the legislative group. And we've already determined that we can share that. You're going to share that with us. But I'm just asking if there was still thought about doing that as a motion, or Mr. Helgerson, you're free to do what you need to do with the legislature.
I think it's implicit in the motion when I started off by saying, in light of the analysis, that means that I think it incorporates it by reference. They would have to.
I agree in terms of what we would do as the agency if asked, or probably in whether we're asked or not. We'll make sure the committees have that information to help guide their decision making too. Okay. Anything else in your report, Tanya?
I have nothing else.
That's plenty.
Okay, thank you.
Okay, thank you. I didn't have anything to update about the project either. I think that's a good discussion and a little is a good transition to our next topic. So one of our charges is to talk about privatization of state hospitals and the implications of that. I've invited a few people to help provide some background and perspective on that decision or on that thought process. The first group that we're going to have speak are from the National Association of State Mental Health Program Directors, which is an association that our agency is a part of, and provide a lot of expertise and guidance to state mental health agencies about a wide range of things, but in particular, or in this case, about state hospitals and how they're operated. And then I also invited Tim Keck, who's a former secretary of KDADS, who has some direct experience, lived experience in thinking of privatization, particularly one of our state hospitals. So what I thought was I'd start with the National Association folks to provide some background, perspective, best practices on privatization and state hospital capacity, and then have Tim kind of give his perspective and then open up for questions from there. So Dr. Hepburn, I may start with you if you want to kind of introduce your team or provide your comments, and then move around to Ted and others, or kind of follow your lead on how you'd like to start the discussion.
Yeah, thank you. I appreciate being able to listen to some of the previous discussion. So I'll try and make some points that are relevant to that previous discussion, and then I'll ask Ted Lutterman from NRI to weigh in, and then Wendy Morris, who was recently the commissioner in Kentucky and has some direct experience with privatization. I'll ask her to comment third. So yeah, we're NASHBID, National Association of State Mental Health Program Directors. We work with all the commissioners of mental health throughout the country, and our goal is to help improve access and improve quality of mental health services. Our focus has really been on community services and having a continuum of care, an effective community service will decrease the pressure on emergency rooms, jails, et cetera, and decrease the need for hospital beds. So our first priority is making sure that the needs of the community are met and that there's a full spectrum of services within the community. Otherwise, what happens is that all the emphasis is on building new beds, and those beds will be, if you don't take care of the community needs, the beds will be full of people within a year and not necessarily people that need that level of care. So our focus is getting people the care at the level that's needed rather than pushing people to the services that are available. When we talk to states about needing more beds, in addition to the community issue that I just brought up, what they will say is, Brian, we've got more beds than what we can use right now because we don't have the workforce. They say we could build another 100 beds. We don't have the workforce to take care of them. So that brings up an issue of, I don't know what the workforce is like in the county that you're talking about building it. I don't know what the alternatives are. So I'm not speaking with any expertise in terms of Kansas. I'm just saying what other states talk about. Now, interestingly, there's a lot of attention in inpatient in the use of technology, that by using certain technology, you may be able to decrease the workforce needs. So that's something that as you go forward, you may want to look at as part of your capital project. Is there a way to, as you're building a new facility, build in ways that technology may be able to be helpful? In terms of public-private partnerships, many states have worked with the private sector, and what we find in generally in states is if you look at the utilization of state hospitals and you look at the utilization of the private sector beds, it frequently looks like there's an overutilization of state hospital beds and an underutilization of private sector beds. So we really recommend taking a look at what could be done with private sector involvement, because giving an example, in Maryland, there's a hospital called Shepherd Pratt Hospital. And that hospital 20 years ago was almost all private insurance. It is now 70% Medicare and Medicaid. They take care of many individuals who frequently would have gone to state hospitals. How did that happen? Well, you know, a carrot and a stick often helps, but they came to the table, they helped out, and they now feel very good of the product that they have. That product includes inpatient, but it also includes the full continuum of care. So working with the private sector like that, developing a program like Shepherd Pratt, helped not just with beds, but with the full continuum of care. The other thing that I was thinking about as you were having your discussion is there's a lot of attention to the capital budget, necessarily so, but your operating budget is going to be very important going forward, and trying to make sure that you're going to be able to maximize federal dollars. I don't know in Kansas if you use disproportionate share dollars. I don't know if you've solved the IMD issue, but solving those, making sure that you have a good funding base so that you're not going to have to go back to the taxpayers over and over again to get more money is something that's also very helpful. And some states have done a good job through waivers, through working with managed care organizations for in lieu of services, being able to maximize those federal dollars to help with state hospitals. So with that, let me turn to Ted Lutterman. He has some data on privatization of state hospitals. Ted?
Hi, thank you, Dr. Brennan. What Dr. Brennan didn't really mention is he was the commissioner in Maryland for 10 years before he became the executive at NASHBID, and before that he worked at state hospitals in Maryland. So when he was talking about getting Shepherd Pratt as a private hospital to start taking public patients, he was really the person who helped do that. A couple of years ago, well, actually 4 years ago, we had done a report for Alaska that was looking at privatization of their one state hospital in Anchorage. And as part of that, we'd interviewed a number of states that had either done privatization or were considering privatization, and developed a report that sort of summarized some of their common lessons learned for Alaska. Because it had been done for the state, it was their property, but yesterday afternoon, their commissioner did give us permission to share that report with you all. And I sent to Mr. Bruner this morning the part that we really sort of did a literature review of some of what's known on privatization, which that was not on the state hospital side, but really of other hospitals, general hospitals that went privatized. But then there's some descriptions of about 8 states' privatization experiences, ranging from Florida, where they have a mixture of private psychiatric, privatized state hospitals doing the staffing, and state operated ones, to a number of states. In Kentucky is another state that has a couple privatized, and Wendy Morris, who is commissioner there, can speak to that. But I think there were some really potentially helpful lessons learned. You know, some of the states, Florida thought it really worked pretty well to really help them get more flexibility to recruit staffing and to hire staff that they needed. In one of the ones they first privatized was in the Miami area. In another state, though, in Michigan, they considered privatization. They were having huge staffing issues. What they found was, Michigan being a strong union state, was putting privatization on the table. All of a sudden, the unions came to them and were able to be much more flexible. And without privatization, they were able to resolve and change some of the workforce requirements. One of the things was they were hiring lots of nurses out of nursing school. They'd get experience and then get hired to the private sector. And they thought one of the things was the state's staffing rules where people worked 8-hour shifts, and the nurses really liked on the private sector being able to do 4 10-hour shifts or 3 12-hour shifts. And the union was resistant until the discussion of privatization came up, and all of a sudden they were willing to give flexibility. And the state found that really helped resolve a lot of their staffing in terms of retention. So each of that's in the report, which you're free to share with the team if it's helpful. Just a couple of the things that we did hear from some of the states, lessons learned in Florida and some of the states. They really found that to make it work well, they really needed to have a full-time FTE at the department who is keeping on top of the privatization. They include their privatized hospitals in regular meetings along with the non-privatized, the state-operated hospitals. They thought even some of the competition on key measures was helpful. But they also learned early on, one of the times that it was privatized, they shifted vendors, and the company that had been running it tried to claim that all the employee records and materials were proprietary and belonged to them and did not want to share it with the state. So one of the things you'll see in our report was highlighting state after state found that you really need to write any contract around who's privatized very carefully around who owns the client records, what's a transition plan, making sure that, that your staff of the state can access records while people are at the hospital. So there's just a whole series of things that writing the strong contract is critical for it to work well. And if it would be helpful, if you do decide to pursue that path, we'd be happy to try and put some of your people in contact with a couple of the states who've gotten contracts so you could see what language they found most useful. The other piece that we did see was interesting, though. Indiana, Georgia, several states went through an exhaustive process of developing an RFP, put it out, put in the requirements of what they want in terms of the treatment milieu, and ended up getting no bids that actually met the requirements, or the cost would be $3 million to $5 million more than the state continuing to operate it. So in the report, there are several examples of states that considered privatization, but found it was actually going to cost more in their instances for getting a vendor to run it the way the state was specifying. So I don't know if that's helpful or not. There are a couple other recent examples. Washington State last year, they've had huge problems with people backing up in jails and prisons and multi-million-dollar fines from the courts over that. A private psychiatric hospital had closed, and the state for $30 million bought that facility, and they're in the process of opening it up. Right now, I think it's got about 54 patients, but they're going to go to 137 patients. The legislature was just appropriating $140 million for fully staffing it to treat 137 beds, I think it is. But this all happened just in the summer of 2023. They started accepting patients in the fall, and they're expecting by this summer to be at 137 beds. So it wasn't a general hospital, it was a private psychiatric hospital. So it may have been laid out differently, but it was, the ability to take advantage of that to jump on immediately to fill the space. So again, if it would be helpful, we could put you in contact with the people in Washington State who are doing that new ramp up. They just had a big, in the papers, recruitment fair to try and hire staff, their first 200 staff that they hired to get their first set of wards open in the fall. So I don't know if any of that types of examples would be helpful, but we're here to help however we can. And Wendy, you can give some actual real experience running one of the privatized programs.
Yes, thank you, Ted. So again, I'm Wendy Morrison. I currently work with NASHBID as a senior behavioral health advisor, but I did work for the state of Kentucky as commissioner for a number of years. And before that, I worked for one of our state hospitals, specifically one of the state hospital who's run by one of a private entity. So both of these examples are in the report that Ted talked about. I can just give you a little bit more background. So the first hospital that we privatized, state psychiatric hospital here in Kentucky, was a brand new build in Eastern Kentucky, Appalachian Regional Healthcare. I happened to be employed there at the time the hospital was built. And then, as I said, and then I ran that hospital for a number of years before coming to the state. So I kind of know it from both sides. But that facility was built under some legislation, part of the budget that was very prescriptive of, it didn't say that it was going to be ARH's hospital, but it was outlined in such a way that was the only entity that could have possibly run it. So there was no procurement process. They were the only entity that qualified. And then over a period of time, through depreciation and by agreement, the building became it became owned by ARH. It was no longer owned by the state. And I can tell you that that turned out to be pretty problematic down the road. It was a great arrangement for a long time, win-win for both ARH and the state. It was very cost effective. There was high quality. When I took over management of the facility, what I was told by our corporate office was the state of Kentucky is our most important customer. This is our biggest contract. This is a huge responsibility. This relationship is important. But then when the ownership of that facility transferred to ARH and there was some change in leadership, things kind of changed. Like, well, do we really want to keep doing this? We can make a lot more money if we do something different with these beds. There's a lot of medical need. And so I think to Ted's point, how you contract it and what it looks like and what you maintain control of and what you give control away to when you enter these public-private partnerships is really important. And you have to really kind of think ahead of time. Right after I came to the state, I guess within the first year, we privatized the Eastern State Hospital, which is in the central part of the state. In that instance, it was also a brand new build, but the state maintained ownership of it. We contracted with the University of Kentucky to run it. Now, the old 1800s building that we were replacing a few miles away had been run by one of our community mental health centers. But there were some issues the state was trying to we were looking to do more research. We were looking for an affiliation with the residency program at the university and some other things. But so that contract worked a little bit different. It's been a good arrangement. It's been a lot easier to recruit and retain specifically medical staff at that facility. They actually attained magnet status, which I think is really rare. I don't actually know of any other state hospitals that have been able to attain nursing magnet status. Brian may know, but it was kind of a big deal. It's certainly the only one here in Kentucky that was able to do it. So there are lots of pros. There's a lot of the private sector can be a lot more nimble with purchases, policy updates, changing staff mix. Like I said, recruitment can be easier. It allows the state, from my perspective, to really focus on quality and outcomes instead of that kind of day-to-day management. But there are also cons. It can be more expensive, especially as that relationship changes over time and the people who entered into that original agreement are gone and there's new people with maybe different motivations or different interests. There can be that threat of, well, from the private sector, they don't want to do this anymore, or they may have demands that if you don't meet these demands, we're going to do something else. So there's a lot to think about. I know here in Kentucky, again, one was a university, so that was another, it wasn't it's also a public entity, and then ARH is a nonprofit, and I think both of those arrangements helped as well. But you definitely need a strong contract to protect the state interests. I know that's in Ted's report. Who owns the building matters. Who owns those medical records is important. The staffing and what happens with that if there were a transfer. Another thing I didn't hear Ted mention is really important, and I think it was one of your questions, and that is the relationship with the community sector. That really needs to be talked about a lot and put in contract as well. You really, as a state, want to maintain that authority over over the approval and denial of admissions for two reasons. One, you want to be sure that facility is not denying your more difficult patients. Otherwise, they're going to end up at your other hospitals. So you want people to be able to get care at the facility that's closest to them. And you don't want them turning down for medical reasons or for, issues with behaviors. At the same time, you don't want them to take admissions when they could be served in a crisis center, in outpatient services with an ACT team. There's a whole host of really great and innovative programming happening across the country, including Kansas, of course. And you want to be sure that the community is involved in those admission decisions so they can say, is there something less restrictive that we can offer this patient before the decision is made to admit them. I think those are a lot of the comments I had. I will say, because it's important, neither of the facilities here in Kentucky do forensics. So we have involuntary admissions, 60-day commitments, 360, but there's, and we might do some, like for misdemeanor competency evaluations, and by exception, the commissioner can give approval for somebody to come in who maybe has pending charges, but that would be the exception, not the rule. So I heard you say forensic beds, because I also was on early on the call. That's different. And so that certainly is a consideration when you think about who you're going to enter into a partnership with, because not everybody has that expertise, for sure.
And Dr. Hepburn, you might comment about one of the innovative things Maryland did was you had Johns Hopkins and the University of Maryland Medical School supplying residents at your state hospitals as a workforce approach.
Yeah, just real quickly, similar to what Wendy was talking about with the residency program being close to one of the state hospitals that she was referencing. The University of Maryland has had a close relationship with the state hospital system and the community mental health system since the mid 70s. It goes back to when all the state hospitals had their own residency program and nursing programs. They were really self-sufficient in that way. And then they moved away from that. As part of the move away and the difference in contracts, that was a lot of that funding went to the University of Maryland for those residency programs and also programs with social workers and nurses. But those were the points we wanted to make. We're happy to answer any questions or wait until Tim talks, and then we can answer questions together, however you prefer. It's nice to see Tim.
If that's okay, thank you for those comments. Maybe just I'll take chair's privilege, but there are some examples mentioned in the report, I believe, of states that did have privatized forensic hospitals as well, or where forensic services are included. So although that wasn't Kentucky's experience, that we do have some examples in the reporting about that. Maybe I'll let Tim, if you want to give your comments, Tim, and then we'll open up for questions if everybody's still got some time to stay on for a few more minutes.
Sounds good. First of all, can you hear me okay?
Oh, if you could go a little louder, that would be great.
Yeah, no problem. Is that better?
Yeah, that's better.
Okay. Great. Well, first of all, thank you for inviting me to be a part of this discussion, and consider it an honor. And secondly, congratulations that you've come this far in getting a hospital there in Wichita. I think that's great for the state and certainly for the Wichita area. So congratulations to all of you on this committee, on this advisory panel, and the state in general. I just think it's fantastic. And so I thought a little bit about what I wanted to talk about, and I think, just take you through kind of maybe some revisionist history, hopefully not, of what happened with Osawatomie and what my thought process was for privatization at the time that I was secretary. And I was secretary from January of 2016 to January 2019. And if you recall, Osawatomie, right about 3 weeks before I began as interim secretary, Osawatomie was decertified. And when I took over, we immediately started to try to turn that around. And honestly, it took us a couple of years. And during that time, the RFP had already been worked on, had kind of been completed before I became secretary for the most part, at least the first draft. And at the same time, we were trying to get recertified. We were also working on the RFP to privatize. And a lot of what Mr. Lutterman talked about and Ms. Morris talked about and Brian talked about, it seems like we lived to some extent. With the RFP, we ended up getting only one bidder. And so we worked with them to try to move forward with privatization. And at that time, we were trying to also build a new hospital at Osawatomie. Most at that time, and I think it's probably the same today, but at that time, the most recent building that had been built at Osawatomie, I think in the 60s or so. And so we were trying to do two things at once. And And I'll tell you in retrospect, that was probably a mistake. We probably should have just tried to privatize the operations and or staffing in retrospect. And I honestly, I think we once we only got one bid, we probably should have stepped back and worked to do a different RFP that would draw additional bidders and people that would provide that service. But really, the overall thing that drove our efforts to privatize was the flexibility. And it was certainly about staffing. And some of you are living this every year. At that time, especially, the wages at Osawatomie were much lower than kind of what the market required. And so we had to, although I took over in January, it was pretty easy to get a pay increase. That first year, the legislature was supportive of that, although everybody was pretty, I wouldn't say mistrusting, but really skeptical about what was going on at Osawatomie and why we were in the situation we were in. But they were very supportive of the legislature and the governor, and everybody was really supportive in getting people paid up to market. But we had to do that every year. We'd have to go back and ask for more pay because the market changed so fast during that 3 years that I was there. And then things would happen, like they opened a Walmart distribution center or close to Osawatomie, and people would go work there because it was more pay and frankly easier work than working in a state hospital. So really the main driving factor was the flexibility that you have with privatization. The private entity can adjust their wages, their practices, and those kind of things quite a bit quicker than the government seems to be able to do. And that's not being critical of government, it's just the necessary process of how the legislature works and how the state government works. And then also we felt like because of just the natural course of the way government works, that bringing in a private entity to operate it, not just the staffing but the operations, would bring up the level of quality of care. Honestly, we heard a lot of that. That's the way we've always done it, so that's the way we're going to do it. And we thought bringing in some fresh ideas was the right way to go. Ultimately, we spent a lot of time with the bidder. We did town halls in several cities throughout the state, and we visited with the bidder. We visited their facilities. They had facilities, I think, in Florida, and I don't know, another state. I don't remember which one, but we went to 3 or 4 of their sites to see what it was like and how it was and how they delivered care and those kind of things. We did that with some legislators. So we had a trip. We did that trip and took some legislators with us. So we really tried to make sure we got it right. And it was just a time, I think there probably still is a statute that prevents privatization at the state hospitals. So Scott shaking his head, yes. I think there's probably more than one statute because people were pretty resolute to not privatize at that time. And again, I think that just comes from what the situation was at that time. But ultimately, we were not able to prevail, and not prevail, but be able to get that done. Some of the things I think we could have done different if we had more time and or just from the get-go, probably redo the RFP. So we got through additional bidders. The thing that we needed to probably do in the RFP that we didn't, I don't think probably had quite as strong, was the oversight. And I think somebody said something about 1 FTE. I think we probably need more than that, depending on how much how many facilities you end up privatizing. If it's just Wichita, 1 or 1.5 might work. But if you do all of them, it's going to take at least 1 at each site to do that. And then probably add some additional, I assume, some finance staff and those kind of things. Yeah, and then if we could really address the IMD issue, that would make things a little more plausible, a little easier for the funding streams and those kind of things. But really, the main driver behind it was the flexibility that privatization offers versus government way of doing things. And then we thought they would bring in some new practices, at least at the beginning, and be able to keep up with the best practices as we went forward. So I have several other notes, but I'll stop there because I think they were touched on by Brian and Ted and Wendy.
Thanks for that, for those comments. Open up for questions. Anybody have questions? Joan?
I have one for Dr. Hepburn and one for Wendy. So Dr. Hepburn, you mentioned, and it might be in the report, which we could reference, but did your report contain what technologies might assist with staffing patterns?
Yeah, I can get you, one of my staff actually went to a meeting earlier this week and came back just really enthused at some of the way that technology was being used. One, for example, is that, one of the big cost drivers is when you have an individual on 1-to-1, sometimes 2-to-1, sometimes 3-to-1, so that, let's say they're on suicide precautions, and sometimes you can use technology instead of having additional staff. You can make sure the individual is safe in the room by using technology rather than additional staff. One of the problems we have with additional staff is that if you worked on units, you know that if you add staff, that may make us feel safer, but it doesn't necessarily make the patient feel safer. Often it's seen as intrusive and can actually escalate the problem. So using technology to maintain distancing and to avoid some of that intrusive behavior that we often get into with our nursing in order to make sure that individuals are safe. Some of the techniques you've probably seen in the senior community where they've moved to using technology, sensors, et cetera, instead of having people with eyes on. So, but I can get you some of the, I'll talk to my staff and see if I can get some better references for you, because I thought it was really interesting, especially since we're all working at the disadvantage of shortage of workforce.
Yeah, I was suspecting that's where you were going to go with that, because I know there's a local company working with some DD providers on some enhanced technologies that seem real appealing. And then Wendy, I had a question because you said that you worked in a facility where did privatization. Can you give me a sense on when recruitment occurred? Did many of those folks come from the community in which the hospital was already located in, or did it bring new people to the community?
Well, the hospital where I worked was in Eastern Kentucky, so most of the staff, nursing staff, support staff, ancillary staff came from the community for sure. It was a good source of employment. Most, if not, I guess I would say all of the physicians came from elsewhere. There at the time there was no residency program or way to kind of build our own workforce. Since I've left, which has probably been, I don't know, 12 years, I know they are using a lot more advanced practice nurses and physicians assistants, and those programs are now available locally. They weren't. I was one of the first people to graduate with a master's in nursing way back when, in the 90s. But and then psychology, having a psychology internship program is like the best way to get people to come to your community and to stay.
Wendy said that her internet was a little unstable, so maybe she's experiencing that, but we'll come back to her if when she comes back on. Are other questions that folks have?
You want to share that with?
Yes, I got it this morning. We'll get it distributed this afternoon. Ted, just making sure I was right. So some of the examples, I mean, I read it quickly or read an earlier version of the report, I think, that you presented to the Kansas legislature, but there are states that have done privatized forensic services or entirely
Florida
forensic
has some
facilities.
of theirs some of the Florida are forensic, or they treat forensic patients. I'm not sure I should mention it, but if you Google Bridgewater State Hospital, Massachusetts Forensic Hospital is privatized, is right now in the midst of a scathing report about problems with it. So
Are there anything different from the interviews that you did about those experiences or best practices that are different than for acute mental illness, or is it kind
Well,
of the same considerations?
I think the considerations, I think there's real concern, with the forensic clients, they're really sent by the courts. And so there's that additional level of communication. It's the state mental health agency, but you also have courts deciding who can come in and who can be discharged from the facility. And so it complicates a bit more, making sure that people don't silt up the facility, that they're able to be discharged as soon as they're clinically ready to be discharged and the courts agree. And there's a sort of a different level of security staff, and I think just might be worth checking with the Florida people, but in terms of making sure that there's appropriate training for people when they're dealing with the forensic clients.
I'm sorry, this is Wendy. I'm having unstable internet, and which never happens. I've not had this problem before, but I'm going to keep off camera, so I don't know where I dropped off when I was answering.
Just mentioned about psychology interns, psychology interns being a key part of the workforce pipeline.
Yes. So lots of staff, including social workers, nurses, as I said, were from local, but physicians and psychologists were the two disciplines we really had to recruit from elsewhere. And that's part of that, just a lack of educational programs for those disciplines here in our state and overall national shortage. So I hope that answered your question. Sorry.
Nope. I think so. Other questions?
I was going to say one privatization piece that's in the report sort of talks about next door in Missouri, where they took sort of a unique approach. They closed the acute units at their state hospital and used state funds to incentivize some general hospitals to set up special psych units to take acute patients. In essence, the state hospitals are IMDs and they can't bill for Medicaid. By moving the acute clients to a general hospital, the state was able to use Medicaid to pay for that care. And then the state hospitals are used for people that need continuing care. So if they were in a general hospital psych unit for 30 days and were still not able to be discharged, then the state would take them, or else the state takes forensic clients. So it's sort of shifting where the acute services go to a system that can bill Medicaid in order to keep in the state beds for, for people that need continuing care or for the forensic clients. And the state used some of the money that they were saving by closing the acute units to pay for ramping up and getting the acute units open in general hospitals. So I don't know if you've looked at that sort of IMD implications, but that was an approach that took place next door.
Yeah, and if I could, I'll just follow up on that. So in Kentucky, ARH is actually a distinct part unit. It's 100 beds, and it's connected kind of by not an underground tunnel, but an above ground kind of breezeway. They share ancillary services and support services, but it's not an IMD. It's part of the medical center. For our Eastern State Hospital, it is an IMD because Kentucky has opted not to give that license to the contracting, to UK. But in both instances, when people need medical care, it's readily available, and that makes a world of difference. And we think also kind of, it provides some incentives to go ahead and offer better medical care inside the psychiatric facility. So you don't strain the medical center as well. But from my perspective, been a win-win too, to make sure people get holistic care.
That's a good call out just for the panel's benefit. So at Larned Osawatomie now, we explicitly say we've got very limited capability to take care of people's medical needs. I mean, we can do fairly simple things, straightforward things, but if somebody needed routine dialysis or anything more interventional than probably what you get in a physician's practice, we have to send them out to community hospital. So that's something to think about. We've got to think about that relationship here in Sedgwick County as well. How far, I mean, we're building a medical clinic, but we're not going to be able to do major interventional kinds of things, or we wouldn't admit somebody who had significant health concerns. So that is a little bit different than it sounds like Kentucky's experience, or where you're at least had it more readily available.
And I think that what you're bringing up is an important issue, because one of the big costs of state hospitals is if they have to pay for that medical care, if they don't have a way of having that medical care transferred, so that the individual would be transferred instead of maintained as a patient. I don't know how you do that in Kansas if the state hospital gets billed for the medical care, but that ends up being a significant issue for the state hospital that is hard to anticipate within their budget. So it often causes state hospitals to go over on their operating budget because of that. And if you have it only takes a few people that have serious physical illness that can really drive up the budget. So trying to make sure that those individuals are maintaining their health insurance so that when they're transferred for medical care, that they can use that medical insurance instead of the state hospital being billed for it. That can be a big savings as you go forward.
Yep, good point. There are questions for our guests? Certainly get the report around. That'll give people more information to chew on as well. Not seeing other questions or comments. So I'd like to thank Dr. Hepburn and Ted, Tim, Wendy. Thank you all for attending, and thank you for your patience listening to our discussion leading up to your presentations. I think you have a good sense of the project that we have underway here in Kansas, and the excitement and the kind of struggles of getting to where we are. But thank you for your participation today.
Thank you for inviting us. And I just want to give a word of support and thanks for the commissioner in Kansas. The commissioner of behavioral health in Kansas does a great job, and we work with them regularly, and it's really a pleasure. So thank you.
He's not here, but I will pass it along. I will pass it along so that Drew and Andy are both aware. But they certainly value the partnership and the resources that you all provide. And Tim, thank you for being available and coming back and helping us out with the project and your perspective as well. It's very, very helpful.
Good luck, everyone. Good seeing you.
The last agenda item we have for today is the review of the sub panels. I think you have a document in front of you to kind of describe the couple of meeting, or how we're going to use our April time to work in sub panels. Ryan from Learning Tree is going to walk us through that here quickly and see what questions you have. So Ryan, go ahead.
Thank you. Yeah, Scott mentioned you should have this advisory subpanel work group document, and I believe you've seen these dates probably previously. So the workforce group will be on April 12th in the morning, and then the second date for the workforce will be April 25th in the morning. Law enforcement, as you can see, will be via Zoom as well on April 12th, and then April 26th in the afternoon. And before the first meeting, we will send out and share certainly the Zoom links for those meetings, as well as a condensed version of some essential background information for you to review, and just laid out sort of the agenda for meeting 1 and meeting 2. As you can see there, we'll review the background information, have a brief discussion about it. We'll plan to use some pretty slick software behind the scenes to help us take what is a lot of information and narrow that scope, certainly within the first meeting, get to where we have some general goals by the end of that first meeting. come back in the second meeting, narrow the focus even more, and hopefully come away with some recommendations. And so that will be the process for both subgroups. Currently, we have near 15 people that have either expressed a desire to be a part of the workforce group or who have been recommended to participate. And so we'll confirm that group by the end of this coming week. In regards to the law enforcement sub-panel work group, we're at just under 10. And so I think still accepting, recommendations for people to be involved there. So.
Thanks, Ryan. So so there'll be, again, that's how we'll spend time in April. The workforce group, I think the sort of charge is a little clearer of recommendations around, given what we heard last month from the universities and WSU Tech about and the nursing board of nursing about kind of things they would see if their licensing changes, financial incentives, things like that we need fairly specific recommendations that we can move forward with. We've not entirely missed this legislative session, but effectively we have. So it's things that we can start working on to plan for next session. For the law enforcement group, I think there's, at least from my perspective, there's two kind of critical questions we need to explore with that group. One is at least get some thoughts on catchment areas, as the sheriff mentioned, both for the building, the 52 beds are to go to 104. How big should the catchment area be for forensic cases? We really treat the state as one large, or as one thing, and admit people through either Larned or Osawatomie or this building. But I think that's probably worth discussing to make sure we're meeting the needs of Sedgwick County, but also the region, since that's a focus. So I think catchment area is a discussion to have there. We want to make sure that group's well informed about the competency process, what the wait time and process to get admission to Larned looks like, some of the work that's gone on around with mental health centers, working with judicial districts to do competency evaluation and restoration in the jails, just that kind of framework. But then are there other things we need to do to make the competency process work better? I think those are really the relevant parts for the law enforcement. Sorry, I said two. There's a third. A third topic that came up at the town hall meeting, which was a really good call out, was as we're building this project in South Wichita, if there is a fire or a staff assault at Larned and Osawatomie now, we call local fire department, call local police or local sheriff to come in and help respond to that. We need to make sure local law enforcement is aware of that need as well with this facility, what impact that might have. And again, just it's sort of an awareness and community engagement function, but I think it's better to talk about it now than wait till we grand open and then have a call from 911 to have, need a response to the lobby or something. So I think we can talk about those services and how it works, how it could work better, what concerns local folks in law enforcement and fire EMS would have about supporting a facility like this in South Wichita. So those are three that from my perspective, but certainly we're open to other conversations as well. And then I think the last part is we'll share. We're going through the list with Greenbush of everybody that's been either panel members that have volunteered and others that we've identified from the community. But if there are other people, other perspectives we need to draw in, or other individuals we need to draw in, we still got time to get those invitations out and invite folks. So again, as you look at the list and the charges, if there are other people you think that's a voice we need to have in one of these groups, let us know who that is so we can reach out to them. That's the other request of the panel, is additional membership for the subgroups. Any questions about that process there are other things we've been asked to work on, but workforce and the involvement of law enforcement were kind of the two that we wanted to not peel off first, but start working on now and use our April time to do that. other question, and we'll kind of rely on Greenbush to guide that process and also draw out the recommendations. And that's what we've asked them to work on. Pausing for comments. Don't see any or hear any. Any last items or questions from the panel before we adjourn for the day? Or future topics that you want to hear about that we can start working on? Joe.
When we meet as a workforce group, will we get a sense of what the staffing pattern would be for a 52 and a 100? I think that really kind of is contextual. Thinking about where workforce development needs to.
Sure. Yeah, we can absolutely. Yeah, by that point, we'll have a pretty good design or pretty good model figured out of what we're building to in the construction process and what we need for the program. We're going the right direction. We're starting with the program, what we need clinically, and we have to make sure we have enough space, but that's for April. Again, I'll send the documents that Tanya passed around. It'd be great to walk through the building design with all of you in more detail. We can probably do that in our May meeting, or as we get to that point and really start kind of visualizing the project as well. So I think that'll be helpful for you all to see. We've got a few more steps to take along those lines, but we're getting close. All right. There isn't anything else. Very good work today. Thank you for your input. And I don't think I'm underestimating what you're all willing to do and what you're willing to make decisions. So I apologize if I'm underestimating it, but thank you for the direction today. It's extremely helpful. Thank you again to our guests. And unless there's an objection, we'll stand adjourned for today. Hearing none. Thank you for your time. Have a great weekend. Thanks, Henry.